Hello, my name is Dr. Carolyn O'Donnell. I am a second-year pharmacy resident focusing on psychiatry at the University at Buffalo and Buffalo Psychiatric Center. And today I will be presenting on the medication management of major depression. So the learning objectives are to list the presentation, symptoms, and diagnostic criteria of major depressive disorder, review optimal therapeutic regimen guidelines, and describe how to assist the pharmacist in monitoring for the effectiveness of the selected therapy. Some key concepts include extensive treatment guidelines are available to assist in the treatment of major depressive disorder, or MDD, including medication management. Clinicians treating individuals with MDD should be familiar with these guidelines. When evaluating a patient for the presence of depression, it is essential to rule out medical causes of depression and drug-induced depression. The goals of treatment for depression are the resolution of current symptoms, such as remission, and the prevention of further episodes of depression, such as relapse or recurrence. When counseling patients with depression who are receiving antidepressant medications, the patient should be informed that adverse events might occur immediately while resolution of symptoms may take 2 to 4 weeks longer. Adherence to the treatment plan is essential for successful outcome, and tools to help increase medication adherence should be discussed with each patient. Antidepressants are generally considered equally efficacious in groups of patients with major depressive disorder. Therefore, other factors such as age, side effect profile, a past history of response are used to guide the selection of antidepressants. When determining if the patient has been non-responsive to a particular pharmacotherapeutic intervention, it must be determined whether the patient has received adequate treatment at an adequate dose for an adequate duration, and whether the patient has been medication adherent. And then pharmacogenomic tests are now commercially available. However, there's no standard or well-accepted recommendation for the use of pharmacogenomic testing as it relates to antidepressant treatment for major depressive disorder. When evaluating response to an antidepressant, in addition to target signs and symptoms, the clinician must consider quality of life issues such as role, social, and occupational function. In addition, the tolerability of the agent should be assessed because the occurrence of side effects may lead to medication non-adherence, especially given the chronicity of the disease and the need for long-term medication management. So, major depressive disorder. This is diagnosed when one or more episodes of depression when a patient has one or more episodes of depression without mania or hypomania. The reason that that's classified is if a patient has mania or hypomania, then we have to start thinking about bipolar disorder. This is really crucial because a lot of medications that you're taking for depression, if you take those medications as monotherapy, so if you're taking an antidepressant as monotherapy, it can actually cause mania in someone with bipolar disorder. So it's very critical that you look at patients and make sure that their diagnosis is for depression, because you want to treat someone with depression with antidepressants, but someone with bipolar disorder should not have antidepressant monotherapy. Guidelines for treatment are available at psych.org and the British Association of Psychopharmacology. So overall, there is a high prevalence of major depressive disorder. According to the National Alliance on Mental Illness, 7.8% of the adult population in the United States has had a major depressive episode within the last year, which equates to roughly 19.4 million people. Depression can also lead to other comorbidities. people with depression have a 40% higher risk for developing cardiovascular and metabolic diseases. 85% of patients with depression have at least one comorbidity. 61% of patients with depression have another psychiatric comorbidity. 30% of patients with depression have a comorbid medical diagnosis. Depression is a leading cause of disability throughout the world and costs $1 trillion per year due to lost productivity, and a lifetime risk of suicide for patients with untreated major depressive disorder is as high as 20%. And with each episode of depression, the risk of suicide increases for that patient. Medical conditions can also cause depression, and often those who are diagnosed with a new disease, especially something that may be chronic, so something like diabetes, or if you're thinking about a large change or a large medical diagnosis, such as heart attack or stroke, those patients with diabetes, stroke, heart attack, with that diagnosis can have more instances of depression. And so if someone is diagnosed with a new chronic illness or an illness that is life-changing, it can be beneficial to recommend screening that patient for depression, because untreated depression can put people at risk for suicide. So really, as a pharmacist, I'm looking to screen people for depression when possible. And if there's ever a patient that you see come into a pharmacy who has some sort of new chronic illness or some sort of illness that's life-changing, it might be a good idea to recommend to screen that patient for depression. So about 1 in 10 Americans who are 12 years and over takes at least one antidepressant medication. So you can kind of see with this chart, although it is an older chart, how the breakdown of the age groups occurs for antidepressants. Overall, depression is a chemical imbalance and it alters neurotransmitters. The cause behind this alteration is controversial. And in addition to altered neurotransmitters, there are also abnormalities within neuroendocrine. I won't go too far into detail, but it is important to know that the full cause of depression is not entirely understood. It is unknown, it is complicated, and so you can read through this slide, but overall, know that it's not entirely understood. Anxiety can sometimes be the first symptom to appear with depression, and often people will not notice they have depression until the symptoms become more severe. On its own, if a patient has mild depression, depression may resolve, especially with things like psychotherapy, but oftentimes depression will become more serious that it requires a greater degree of intervention. If a first episode of depression is under control, then the patient may never have another episode again. And if they are taking an antidepressant for their first episode of depression, it's possible the patient may be able to be tapered off of that medication in the future. But more often than not, repeat episodes of depression are common, and patients may need to try more than one medication before finding one that works. If a patient has depression, it's important that someone has screened them for additional diagnoses and medications that could potentially cause depression as well. So this is just a comparison of how beneficial patients feel certain treatments are for different disorders. So if you're thinking about things like proton pump inhibitors, so things like pantoprazole, patients feel like it really works to treat their GERD. So you see the effect size with this is pretty large. Opioids are also commonly believed to work. So if you look at the oxycodone and acetaminophen, the effect size is still large. So if a patient takes an opioid for pain, typically they're gonna feel like there's a good response to the pain that they're having and that the medication has been beneficial. However, antidepressants have a lower effect size. And then things like statins and aspirin have the lowest, because if you think about it, patients who are taking any sort of statin for their cholesterol, the medication may be changing the labs, but the patient may not feel the change itself. So the effect size is a lot lower for that. Same with aspirin. If a patient is taking aspirin and it's for secondary prevention against things like cardiac events, they're taking the aspirin every day, but they can't feel that aspirin really actively working in their body. They may have less cardiac events, but the patient themselves may not realize how the medication's working or feel like the medication's effective, because it's a little bit harder for them to really see that, except in the fact that it might prevent these effects. Now, this is important because as you're looking at this, since the effect size for antidepressants is a little bit lower, it really is important to realize that patients can often be non-adherent to these medications. Especially when patients start taking antidepressants, they may experience a lot of the side effects, but they may not experience the benefit. And then once patients do experience the benefit of these medications, it's kind of difficult for a patient to really understand how the medications work, because if you've been taking these medications for a while and all of a sudden you start feeling good, you may not think I'm feeling good because of the antidepressant. You might just think I'm feeling good. I don't need this antidepressant anymore. And that can lead to adherence concerns, as well as patients suddenly stopping these medications. So with antidepressants, adherence is a really important thing. Before patients' medications get switched or anything like that, adherence should always be assessed by their physician and by their pharmacist. And just looking at it overall, it's important for these patients to realize that being adherent to these medications is really crucial to feel the effects of the medications and to not experience those side effects if you discontinue a medication too quickly. So with depression, the presentation of it has both emotional and physical symptoms. So a patient may experience decreased pleasure, where something they used to really love to do, something that was fun for them or that they engaged in all the time, no longer brings them pleasure. Patients also may have feelings of worthlessness, sadness, feeling blue. And then sometimes there also might be psychosis aspect to it, and they may need stabilization with an antipsychotic, but that is more rare. And then physical symptoms can include things like slowed movements or speech, agitation, chronic fatigue, or pain. And that can be more common in older adults. There's also concerns with things like sleep disorders and changes in appetite as well, whether it's sleeping too much or too little, eating too much or too little. Medical diseases and medication can often exacerbate depression. So it's important to realize the things that can make depression worse. So these are just different things that may contribute to a patient's depression overall. So things like medication-induced causes, so beta blockers, calcium channel blockers can, clonidine, methyl-dopa, reserpine, anti-epileptic drugs, hormonal things like oral contraceptives, steroids, tamoxifen, and then also things like immunologic agents, smoking cessation medications, acne treatment, as well as things like opioids, stimulants. There's a pretty extensive list of medications that can contribute to depression. And then also there's different medical causes that contribute to depression. So things like hypothyroidism. So a patient with hypothyroidism, one of their symptoms of hypothyroidism might actually be depression. So if a patient has depression, it can be caused by other things. It may not be that they need a depression diagnosis. It might be influenced by either other medications or other medical causes. So common medical causes include hypothyroidism, anemia, HIV, AIDS, sexually transmitted diseases, autoimmune diseases, cardiovascular diseases, neurologic disorders. So what is major depressive disorder? So you can see that it says the DSM-5, and that's the Diagnostic and Statistical Manual of Mental Disorders, 5th edition, or the DSM-5. And that defines major depressive disorder as 5 or more symptoms present during the same 2-week period. And it must represent a change in functioning. At least one of the symptoms must include a depressed mood or loss of interest or pleasure. So symptoms include depressed mood most of the day, nearly every day, markedly diminished interest or pleasure in all or almost all activities most of the day, nearly every day, significant weight loss or weight gain or decrease or increase in appetite, insomnia or hypersomnia nearly every day, psychomotor agitation or retardation nearly every day, fatigue or loss of energy nearly every day, feelings of worthlessness or excessive or inappropriate guilt, diminished ability to think or concentrate or indecisiveness nearly every day, recurrent thoughts of death, not just fear of dying, but recurrent suicidal ideation or thoughts of death without a specific plan, or a suicide attempt or plan for committing suicide. And then again, to fit this criteria, the patient must not have a history of manic or mixed episodes, because that might lead more to the diagnosis of bipolar disorder. The DSM-5 has newer depressive disorders section that includes specifiers to help guide the principles of treatment. Previously, bereavement was excluded as a depressive disorder, but now it's included within the DSM-5 if it lasts for 2 months or longer. So the chemicals in the brain need to be recalibrated, and therefore we need to treat it like depression to help rebalance those chemicals in the brain if someone is dealing with bereavement for at least 2 months. For suicide risk and evaluation, it is important to be comfortable having that conversation with patients. So there's something called mental health first aid, which is a cool program because it teaches you how to talk to anybody about things like suicide. And it doesn't mean patients per se, it can also be friends, family members, colleagues, just being comfortable with having those conversations to help with someone who might be in a bad place and might have a risk of suicidality. So asking questions like, are you feeling like you want to kill yourself? Are you having thoughts of suicide? If so, do you have a plan? So this list here is just risk factors that may enhance risk. So male, single, or living alone, describing feelings of hopelessness, suicide plans, substance abuse, unusual behavior, missed work, giving belongings away. And during the initial stages of medication therapy, risk can increase. So it's important, even though these are risk factors for suicide, you should really realize that this conversation is important for all patients. And there are different screening tools that can identify suicide risk. So things like the PHQ-9 has a question about suicide, Columbia Suicide Severity Rating Scale, So you can always talk to your pharmacist if the pharmacist is counseling a patient and maybe didn't have that conversation about suicide risk. It's good to bring it up because patients should be screened for suicide risk. And then make sure that they're not always only screened, but if a patient does have a suicide risk, that there are resources available for how to help that patient. For instance, having access to a suicide crisis phone number, know when the patient may need hospitalization, if their risk is significant, etc. And then I mentioned that during the initial stages of medication therapy, risk can increase. So this was shown, and this is part of the black box warning that I will discuss with antidepressants. But the belief is that when a patient starts taking an antidepressant, or if their therapy has changed, like their dose increases or something like that, that the patient may have already had thoughts of suicide, but then the medication itself is kind of increasing the patient's energy, which is allowing them to act out on those plans. So with patients, a lot of times what I will do is I will counsel patients and say, if you notice things like changes in mood or behavior, more agitation, anything like that, and not only counseling patients, but also I would counsel their families as well if it's possible. So going over the black box warning, antidepressants do have a black box warning that shows an increased risk of suicidality. So in 2004, the FDA required a black box warning on antidepressants, stating that in short-term studies in children and teens with depression, there was an increased risk of suicidality. But then in 2007, the FDA expanded that from children 18 and younger to children 24 years old and younger. So it now includes warnings about the increased risk of suicidality in young adults 24 years old and younger, especially at the early stage of treatment. So again, the medication can increase the patient's energy and the patient may still have depressed thoughts. So that's one of the theories as to why they think that there is an increased risk of suicidality, is they have more energy to carry out those feelings. So what to do with the black box warning? Although I said that the black box warning is for patients 24 years old and younger, it is important for all patients to know about the black box warning. Just because someone is over 24 does not mean that their risk of suicidality goes away. All patients with depression can have a risk for suicidality. So I will typically counsel all patients on the black box warning overall and how to not only screen for that, but then also what to do if the patient needs help and how to get help immediately if it is needed. So with these antidepressants, it can take about 8 weeks for the patient's medication to really be effective. And so that can be hard for some patients because patients may think that the second they start taking a medication that it's going to start working. So first is the acute phase, which can last 6 to 12 weeks. And during that phase, you hope to have remission or the absence of symptoms. And then after the acute phase, once the patient has a medication that is working and they are feeling better, they go to the continuation phase. So typically, after the 6 to 12 initial weeks, the patient will continue the medication for an additional 4 to 9 months. So their therapy, acute phase plus continuation phase overall, is about 6 to 12 months. Now, at this point, It's possible for a patient to discontinue their medication if they've only had one episode of depression. If they're doing well with their symptoms, it's possible that they might be tapered off of their medication. However, a lot of patients will need to take lifelong therapy. And so lifelong therapy is for patients who have 3 or more depressive episodes. So if they have 3 or more depressive episodes, that means there's a high risk of recurrence. And so the reason I really bring this up as well is ideally we want the first medication they take to be effective. So that way we don't have to worry about recurrence. And with that, it's important for the patient to be adherent to their medication, because if they're not adherent to their medication, the medication's not going to work the way it should. It's important for the patient to know the side effects of the medication and how long that therapy takes to kick in before it really starts to work, because the patient really needs to give it the best try they can when they start therapy. So with treatment expectations, this is just a way that you can see exactly what the patients will experience or will likely experience for each of the weeks that they're taking the medication. So week 1 of taking the medication, they might see a little bit of decreased anxiety, a little bit of improved sleep, improved appetite. And then weeks 1 through 3, that's when they really have more increased activity, sex drive, self-care, and memory. Thinking and movements become more normal. So that's movements being some of those physical symptoms that they might experience. And then sleeping and eating may become more normal. So they may not sleep too much or too little, or eat too much or too little within the first 1 to 3 weeks. However, that does not mean that the patient is experiencing complete relief of the medication. And then weeks 2 through 4, that's when the patients can start to see the relief of the depressed mood and the thoughts of suicide begin to subside. Although this can take a lot longer. And as I mentioned, it's often 6 weeks is really where the medication is effective. And that can even be up to 12 weeks where it takes medication to take full effect. With antidepressants, again, it can take time for the medication to start working. And then weeks 4 to 8 is when you really want to see the medication taking full effect. If the patient experiences a partial response where they see a little bit of improvement, but they're not where they want to be, or no response, the physician may need to make some changes. So if the patient has a partial response, they're seeing a little bit of effect, but it's not what they want, it's possible that the patient's dose may need to be increased, or they're experiencing partial or no response, they may need a different antidepressant or to try augmentation therapy. So what a response to an antidepressant means is that a patient has a 50% reduction in this rating scale called the Hamilton Depression Rating Scale. And another one is the MADRS. That's another scale that can be used. However, patients usually will talk to their physicians depending on in that 4 to 8 weeks if they're having relief of their depression. So patients kind of need to think about it for themselves to see how they're improving. One thing that I think is helpful for patients is if they have the ability to journal. So for instance, if they write down their mood every day on a scale of 1 through 10, we have pain scales 1 through 10, but even just writing down their moods and kind of assessing their moods throughout the day can be beneficial, because it is tricky if a patient goes into their physician and their antidepressant has been helping them and their depression has been getting better and better and better. But then the day that they go to see their physician, their psychiatrist, just all these terrible things happen, because then they may think just because of that one day that their antidepressant is not working because they're having a really bad day. So I like having patients journal exactly how they're feeling each day because it can help for patients to look back and see, oh, I've been improving overall, or no, I really haven't been improving the way that I would like. And it's been that 8-week time period. I want to start looking at other options. And then if a patient were to take the medication and then they started experiencing a manic episode, that is often when a patient needs to meet with their psychiatrist, and they can start talking with their psychiatrist about the potential that maybe they were misdiagnosed and they might have bipolar disorder rather than depression. So looking at treatment options, non-pharmacologic therapy is important for patients with depression. If patients are taking medications alone are not shown to be as beneficial as if you add in things like psychotherapy. You really shouldn't use psychotherapy exclusively in severe patients. Severe patients should have some sort of medication with their treatment, but psychotherapy is important for patients with depression. And combination between psychotherapy and medications is really best practice. For mild cases of depression, patients can think about just psychotherapy alone. They may not need medication or anything like that, but they'll need to be reassessed to see if their depression becomes any more severe. And then there are different options like cognitive behavioral therapy, transcranial magnetic stimulation, electroconvulsive therapy, and things like electroconvulsive therapy would typically be reserved for patients with severe depression. So moving on to treatment options, I just want to discuss different types of treatments. And as you're looking through the different treatment options for depression, it's helpful to know the class of the drug, because medications for depression, the classes can really have side effects overall. So if you know that a medication is an SSRI, you know the class effect of those medications, what side effects SSRIs have as a whole. And so that's beneficial because you will know the side effects that go along with it. It's also important to know dosing ranges, drug interactions, monitoring parameters, adverse effects, and therapeutic controversies. And then treatment mechanisms are based on different neurotransmitters, which include serotonin, norepinephrine, and dopamine. So for pharmacologic treatment, there are extensive treatment guidelines available, but there's no universally agreed upon option for treatment-resistant depression. Interestingly enough, all antidepressants are considered equally efficacious for the treatment of major depressive disorder. So if a patient is receiving an antidepressant, the way it's decided what medication they should get, if they all work pretty much equally as well, is really the side effects of the medications and looking at the patient. So that should really help guide the treatment overall. So general issues include things like activation of mania. So again, if a patient is misdiagnosed with depression and actually has underlying bipolar disorder, the use of an antidepressant, an unopposed antidepressant, so an antidepressant as monotherapy, can cause a manic or mixed episode. And so that can be cause for concern, and also typically would lead the psychiatrist to think of a different diagnosis for this patient, because if a patient who they think has depression has an antidepressant that they're taking alone without any other types of psychiatric medications, and then they have that manic or mixed episode, then the psychiatrist should really think more about, do they have bipolar disorder instead? And then failure to respond to one antidepressant within a certain class does not predict another failure to respond to another within the same class or the entirely different class. So what I mean by that is if a patient fails one SSRI, it doesn't mean that they can't use SSRIs overall. They can still try another SSRI or they can go to a different class. Just failing one medication option doesn't cancel out that class or antidepressants overall. And then up to 60% of patients will respond to an antidepressant compared to 40% respond to the placebo. So the first class of medications to talk about is the selective serotonin reuptake inhibitors, or SSRIs. Now, again, just kind of looking at these medications, it takes 2 to 4 weeks to start to see symptom resolution, and patients will be on these medications for a minimum of 6 to 12 months. And that would be if they've only had one episode of depression. Otherwise, they can be on these medications for longer. With SSRIs, it's important to know that if patients have a response that's extreme and it happens in less than 2 weeks, that might be either the increased risk of suicidality or potentially a risk of mania in patients who have bipolar disorder. So patients should be aware of any mood changes and monitor how they're feeling with these medications. With SSRIs, it's important that the psychiatrist working with the patient tapers off these medications. So these medications can have discontinuation syndrome if the medication is stopped too quickly. So with an SSRI, it's important that the dose is decreased rather than a patient just stopping the medication. The exception to this would be Prozac or fluoxetine, and that's because it has a really long half-life. So as the patient stops the medication because of the long half-life, it kind of slowly works their way out of the system. And then there may be initial anxiety with these medications. If the patient's experiencing too much anxiety, then typically the best way to go is to start slow and use lower doses. For educating patients about SSRIs, things that I will talk to the patients about include insomnia or sedation. So if they're experiencing either of these, you can change the timing of the dose, sexual dysfunction, and serotonin syndrome. And so I'll go further into serotonin syndrome. So it's important for patients to know about serotonin syndrome and how to avoid it. Serotonin syndrome can be caused if the patient is taking multiple serotonergic drugs, and signs and symptoms of serotonin syndrome can include agitation or restlessness, confusion, diarrhea, sweating, tachycardia, hypertension, dilated pupils, loss of muscle coordination, muscle rigidity, twitching muscles. And so patients should not be taking multiple serotonergic drugs together. And not only can these include things like antidepressants, but they also can include the triptan migraine medications, fentanyl, tramadol, nausea products like Zofran and Reglan, buspirone, linezolid, ritonavir, and drugs that impair the metabolism of serotonin. Other drug interactions of SSRIs include medications that have QTc prolongation, and then there's also an increased risk of bleeding for patients who take things like non-steroidal anti-inflammatories, antiplatelets, and anticoagulants. And then these medications can also cause hyponatremia or low sodium, which can, if it gets too severe, can lead a patient to a hospital. So at our facility, we will monitor patients' sodiums once a year, or if there's any sort of changes in how the patient is acting, such as things like confusion, stuff like that, then we will monitor their sodium. So this is just a list of SSRI agents. You can look through those. On the left-hand side is the brand names, followed by the generics, the indications for use. So you can see depression for all of these except for fluvoxamine, which is indicated for obsessive compulsive disorder, as well as the dosing for these agents. And then this just goes through and is another chart that shows what these medications are approved for. If they're approved for major depressive disorder, generalized anxiety disorder, obsessive compulsive disorder, panic disorder, post-traumatic stress disorder, premenstrual dysphoric disorder, social anxiety disorder, and bulimia. And then these are the SNRI agents. So before it was the SSRI, these are the SNRIs. And again, it shows the generic name, brand name, indications, and dosing. And then the FDA approved indications for each of these medications as well. So you can see with the SNRIs, if, for instance, a patient has something like neuropathic pain, and then on top of it, they have depression, then an agent like duloxetine is a good agent for them because it means that they're taking less medications and it can potentially help out with two different things that the patient is experiencing. Next is tricyclic antidepressants, and these are often associated with cardiac adverse events and anticholinergic adverse events as well. So you can see they're typically indicated for major depressive disorder, insomnia, and nocturnal enuresis. These are used less because of the side effects as well as the drug interactions that go along with these. So the mechanism of action for the tricyclics is not fully understood, but it's believed to influence serotonin and norepinephrine. And again, side effects really include anticholinergic and cardiovascular side effects. And these can have cardiovascular, ventricular tachycardia, and heart block, which can be lethal in overdose. So that's another concern with these medications is if a patient were to have these medications and they had a strong risk of suicide, these medications can be lethal in overdose. These medications are also very sedating, so patients should take them at night, and they can cause cognitive impairment as well as urinary retention. Other counseling points for these medications include weight gain, sexual dysfunction, drug interactions, and then patients should have a baseline EKG. And these do have withdrawal when these medications are abruptly discontinued. So here's a list of the tricyclic antidepressants. Again, the generic names followed by the brand names, the indications for use, and the dosing available. Next is the monoamine oxidase inhibitors, and these are typically reserved for last line. And so I'll go through some of the side effects with these, but these medications are less ideal for patients who are looking for an antidepressant. So these have many drug interactions. After stopping these medications, after stopping another medication that would interact with these, you have to wait 4 to 5 half-lives before this medication is started. So, for instance, since fluoxetine or Prozac has a long half-life, a patient who's taking fluoxetine would have to wait 5 weeks after discontinuing the medication before they could start one of the MAOIs. For vortioxetine, patient would need to wait 3 weeks before starting an MAOI. Other SSRIs, if a patient were to stop taking the SSRI, they would need to wait at least 2 weeks before starting an MAOI. MAOIs also not only have drug interactions, but they have food interactions. And these are foods that contain tyramine. And what that means is foods that are aged, cured, dried, smoked, fermented and pickled foods. So things like aged cheeses, dried or smoked meats, pickled vegetables, etc. Patients need to avoid these foods because it can lead them to a hypertensive crisis. And this can often be a difficult diet for patients to adhere to because it's not like a patient can have some of these foods. A lot of these foods, a patient cannot have at all because of the hypertensive crisis risk. So because of that, that's another reason these medications really aren't prescribed too often. Other adverse events include things like anticholinergic side effects, diarrhea, postural hypotension, sexual dysfunction, and the patient's blood pressure should be monitored when taking these medications. So this is the list of MAOI inhibitors. So again, the brand names, generic names, indication, as well as the dosing for these medications. And then this is a list of different dietary restrictions for these medications. So you can see the list itself is quite extensive, and it's a lot of foods that people will consume throughout their daily lives. So it is a difficult diet to adhere to. And then this is norepinephrine and dopamine reuptake inhibitor. So that would be bupropion at the top, or Wellbutrin. And that can be used for depression, seasonal affective disorder, as well as smoking cessation. One of the benefits of bupropion is not only that it has smoking cessation as an FDA-approved use, but this medication causes less weight gain than other antidepressants, and it will often cause less sexual side effects. So some patients will prefer the medication because of that. And then there's mixed serotonergic effects, so nifazodone, trazodone, vilazodone, and vortioxetine. And then there's also mirtazapine or Remeron, and that's a mixed serotonergic and alpha antagonist. And so with these medications, vilazodone and vortioxetine are newer medications, and they work a little bit differently. They have things like they do have less sexual side effects as well. And then mirtazapine, that medication causes a lot of sedation and weight gain. So if a patient is having trouble sleeping at night and they're not really eating and you want them to gain weight, and you want them to have more sleep overnight, mirtazapine can be a beneficial medication, but for patients who don't want those side effects, it's a medication that would be less desirable. So again, adherence is extremely important with these medications, and patients are a lot more likely to be adherent if their medication regimen is less complicated. So if they are taking 10 different medications throughout the day, it's going to be hard for them to remember to take medications. Even if they're taking one medication, but they have to take it 3 times a day, remembering to take it every single day, 3 times a day, can be very complicated. So really, you want a patient to be on a medication where they're taking it something like once daily, because adherence is most likely when that's possible. So monotherapy is ideal. The least amount of times per day and the least amount of medications is ideal for patients. With depression medications, if the patient is not adherent to them, then that will make it so they won't experience the relief that they want. But then you also have to worry about things like discontinuation syndrome. And then depending on patients may require augmentation, but really these are the therapies for depression if you're thinking about monotherapy. So for optimal therapeutic regimens for patients, patient preference is very important. Patients know what they like and don't like. Again, if a patient is extremely concerned about weight gain with these medications, then maybe choosing an agent that has less weight gain would be beneficial. So that's kind of how I think through that process and make sure that the patient received a medication they're looking to take and looking to be adherent to. If a patient needs more sleep, needs less sleep, then if they're experiencing insomnia or hyposomnia, then certain agents might be preferred for the patients. And then there's also certain medications that are not good for patients with specific conditions. So bupropion is not good for people with seizures because it actually lowers the seizure threshold. So it increases the risk of seizures. If patient has a substance use disorder, benzodiazepines are less ideal because they have a high risk of addictive properties. And so looking at other agents would be the first thing to do for those patients. Patients who have cardiac complications, tricyclic antidepressants should be avoided. And then GI bleeding and anticoagulation, that's a concern with things like SSRIs. So just understanding the patient, and the way I look at it is, does this medication make sense for the patient? So again, thinking about IESC or indication effectiveness is I, E, S for side effects, and then C for convenience or adherence. So looking at the patient's ability to be adherent to the medication. So once a regimen is selected, how do we monitor for effectiveness? And that can be things like serum concentration, side effects, remission of target symptoms. So a lot of times those depression rating scales can help with remission of target symptoms. So that's just different ways that patients are screened for effectiveness of the medications. And then looking at different special populations who may take antidepressants. So starting with elderly patients, there's the Beers list, which is going through and says which medications are less optimal for patients who are elderly. It doesn't mean if something's on the Beers list that they cannot take the medication. It means that there should be caution used if you're going to give a patient a certain type of medication. So really with the Beers list is to help guide therapy as far as really weighing benefits versus risks. So oftentimes people who are elderly may experience depression, and an SSRI is usually the best choice as an initial treatment. Second choices would be bupropion and venlafaxine. Mirtazapine, as I mentioned, will cause patients to sleep and also gain weight. So if an elderly patient is not sleeping and needs to gain weight, it might be a good medication, although you want to watch the cholesterol with it. And it's important to avoid tricyclic antidepressants in elderly patients. For children, if they have uncomplicated mild depression, they can do psychotherapy before you want to start, or before it's any sort of medication is initiated. And then on top of that, there are some medications that are approved for children. So for example, fluoxetine is approved for children 8 years and older. Escitalopram is approved for children 12 years and older. So with children, again, the black box warning was specifically written for people 24 years old and younger. That being said, I will counsel all patients, regardless of their age, about increased risk of suicidality. But with children, if they're taking these medications, they should be aware of the fact that there's an increased risk of suicidality, and their families should be as well. And the signs and symptoms to look out for that, like mood changes, agitation, etc. And so this is just a chart showing approved options for children and what they're indicated for. And then another special population is pregnancy. So with pregnancy, it's a look at how the benefits and the risks compare, because you don't want a pregnant patient to not be treated for depression and then have a risk of suicide. So pregnancy does not protect against depression, and if it's untreated, it can result in relapses. and depression can adversely affect the development of the child. SSRIs are most commonly prescribed in pregnant patients, but paroxetine should definitely be avoided in pregnant patients. So whenever I see patients who are of childbearing age that could potentially be pregnant or get pregnant anytime soon, it's good to avoid paroxetine as a general rule of thumb. And then treatment-resistant depression. So with treatment-resistant depression, patients may have treatment-resistant depression if certain things happen, like they're not adherent to their medication, their dose was too low, something like that. So first thing that I will investigate is whether or not the patient's been taking their medication, if it's been at a good dose, if it's been for the time period where it's at 4 to 8 weeks for the medication to really start kicking in. And then if I realize that that's all been the case and the patient is still experiencing this depression, that's when it's worth having this conversation about if they should be taking a different antidepressant. So the options are to switch to an alternative antidepressant class. And with that, medications can be cross-titrated where you decrease one dose and start increasing another dose. Combinations are also possible, such as an SSRI or SNRI and bupropion or mirtazapine, or an SSRI plus a tricyclic. With refractory patients, there's no support for using 2 agents in the same class. And augmentation is an option, but there are risks associated with it, such as different adverse events. So things like atypical antipsychotics can cause weight gain, increase in cholesterol levels, increase in things like blood glucose, A1C. So it may not be the best option unless a patient really needs something for augmentation, or maybe they're experiencing some of the psychosis. So again, atypical antipsychotics, here are some examples of it. So there's also the Symbyax, which is the olanzapine fluoxetine combination. So this is just a list of some atypical antipsychotics that may be used in treatment-resistant depression. But again, it does come with additional risks. So it's really not used unless the patient has treatment-resistant depression, and then the benefits do outweigh the risks. So with that, that is the end of my presentation focusing on major depressive disorder. Thank you for listening.